Another version of it that came out recently, in recent years, is called Histotripsy, which I've been honored to offer one of the first 3 cases in Ohio. And this is a treatment where we use ultrasound waves to do the ablation without a needle even. So there's no Band-Aid even. Patient comes in, we put a device on their body, we target the tumor, we kill the tumor, they go home. So that's the future.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Welcome back to part 2 of our conversation with Dr. Mina Makary, a dual board certified vascular and interventional radiologist at The Ohio State University Wexner Medical Center. He holds several leadership positions there and has introduced multiple cutting-edge service lines. His work focuses on making radiology patient-facing and expanding access to minimally invasive therapies. If you haven't listened to part 1 of our episode, I highly suggest that you go back and listen to part 1 with Dr. Makary, where we covered the basics of interventional radiology and a bunch of other subject matter. So if you haven't listened yet, feel free to go back. And if you don't want to, that's fine too. Part 2 of our conversation is where we really started to get into the specifics of the cutting edge work that Dr. Makary is doing. And to some degree, it almost made me a little bit frustrated, not at Dr. Makary at all, but at the gap between what is possible and what most patients even hear about or come across in their everyday life. We dive into cancer ablation, where patients go home the same day with nothing but a Band-Aid. We talk about fibroid treatments that don't require a hysterectomy, knee pain relief that lasts for years. I kept thinking about the people I know who have gone through procedures to solve these problems, larger procedures, more dangerous procedures that didn't have any other options. And I think that's why I found this conversation with Dr. Makary just so engaging. He's a fascinating speaker. And he has a passion that runs through all of the work that he does. So please enjoy part 2 of our conversation on the cutting edge technology going on in interventional radiology, and enjoy the show. Welcome back to our conversation with Dr. Makary from Ohio State University. A couple of weeks ago, we were talking about, interventional radiology. We were having high level conversations about what they're up to at Ohio State, how to practice good medicine, communication practices. But because you're up to so much, I want to hear more about some of the cutting edge work that y'all are doing over there. So before we even get into the questions I have prepared, at the top of the episode last week, you touched on some of the cancer ablation work that you're doing. And I believe you said something along the lines of walk out cancer-free same day with nothing but a Band-Aid. Or some sort of phrasing close to that. I feel like that's where we got to start.
Oh, absolutely. Yeah, so interventional radiology is amazing, and it's in what it offers to patients, cancer patients. And traditionally in cancer, you have 3 pillars of treatment. You have medical oncology, so these are the doctors that provide chemotherapy, immunotherapy nowadays, and other things. You have surgical oncology, these are the surgeons that cut out disease. You have radiation oncology, and these are the doctors that offer radiation. So medical, surgical, and radiation oncology are the 3 pillars of cancer traditionally. Now, the newest pillar is interventional oncology. That is the 4th pillar of cancer care, and this is what interventional radiology offers to cancer patients. And those are usually 2 groups of treatments. Either treatments where we go into the blood vessels directly supplying a tumor and inject beads that have nothing on them, or chemotherapy or radiation. And the beauty of that is that basically, instead of getting a chemotherapy in your IV that goes into your entire system or circulation, you're putting the treatment directly at the doorstep of the tumor inside the body. So all that treatment goes directly in the tumor. And then also you're putting beads that stop the flow. So you're cutting off the blood supply so the tumors die because they don't get oxygen or nutrients or blood flow. And that can be chemo. It can also be radiation. And one of these forms is called Y90 radiation. And it's so effective in certain cases. It's called a radiation segmentectomy. So segmentectomy is a surgery where we cut out cancer. Radiation segmentectomy is because we can select the vessels, supply the tumor, we can give such a high dose that we can actually do a segmentectomy without without cutting the patient up. So those are the ones where we go into the blood vessels. What you're referring to are a group of treatments we call ablation. Those are even more amazing in the sense that we put a needle in a patient, one or more, and we can freeze or heat up a tumor, and we can kill it in real time, and you can see it dying, and then remove it, and then put a Band-Aid and send the patient home. No blood loss, minimal, nothing, no issues. And because you killed it in real time, they're cancer-free. And you don't even have stitches, you're not cutting open, nothing. So this is a very, very, very amazing thing that we offer patients. And obviously it's for select tumors. It can be in the kidney, in the lung, in the liver, in different organs, other organs also. But it's a huge thing because it's very effective and it's minimally invasive. And another version of it that came out recently, in recent years, is called Histotripsy, which I've been honored to offer one of the first 3 cases in Ohio or in the region, and among the earlier cases in the world even, with a colleague. And this is a treatment where we use ultrasound waves to do the ablation without a needle even. So there's no Band-Aid even. Patient comes in, we put a device on their body, we target the tumor, we kill the tumor, they go home, no Band-Aid even. So that's the future. There's a lot of research that we're doing on this and a lot of exciting work in development as well. So that's really exciting. These are the great options that we have for our patients.
I'm imagining all of these tiny little microscopic beads. You say sometimes they have, chemo on them. Sometimes they're just as is. I'm curious, like, are they all the same small little beads or particles? Is it like where you have just a toolkit and they're all a little bit different? And then what happens to them after the procedure, I guess, is my question.
Absolutely. That's a fantastic question. So in the liver has dual blood supply and has arteries and it has a portal vein. And the normal liver gets supplied by the portal vein and the tumors generally are supplied by the arteries. So the reason we can block the arteries, kill the tumors without killing the liver is because it has a dual blood supply. So when we use these particles that you mentioned, and there's different options, they come in different sizes. Depending on the cancer type, the science have shown different chemotherapies or different cancer sizes or particle sizes may be appropriate. And then sometimes we also coat them with radiation and deliver radiation this way. And in some cancers, the ones without anything on them is as effective, so we don't have to give the chemo. That's why there's bland, which we call them bland particles also. They're made of plastic or plastic variants, so they're permanent, unless we want them that way because we want to block the vessels supplying the tumor.
Right.
And we don't want them to open up again and then, the tumor to come back. So they're beads or particles, they're small, oftentimes microscopic, and they come in different sizes. They have different treatments on them depending on the cancer type. And we can do that because of the safety of the other flow going to the normal parts of the liver.
That is it's crazy. Okay. Additionally, so you touched that you co-performed one of the first few cases of the pronunciation histotripsy.
Histotripsy in my state.
Yes, in Ohio. Can you just tell me a little bit more about that before I'll have a follow-up?
Absolutely. So the whole premise of histotripsy is that it's an ablation modality. So ablation is when we burn or freeze a tumor. Sometimes traditionally,
right. I'm super familiar with like a cardiac ablation, right?
Absolutely. So cardiac ablation burns the electrical pathways, the abnormal electrical pathways. So patients' hearts beats through the proper electrical pathways. This is more invasive, more destructive to the tissue of the tumor. And traditionally, people use radiofrequency energy, and then microwave came on, which is heat modality, and then cryoablation, which is creating ice balls to freeze the tumor, and all these can destroy the tissue and kill the tumor. Now, histotripsy uses ultrasound energy, and it's deposited through the skin into the tumor, and it doesn't heat the tissue. It kills the tumor by something called cavitation or mechanical destruction. So it disrupts the tissue. And there are many benefits. Some of them are established, some of them are being researched, but it can spare normal structures around the tumor, which is great. So if you have a tumor next to something, you don't want it to get damaged, you want to kill the cancer, but not the normal structures. It can prime the immune system. So the immune system can be primed through this treatment, so it can actually start attacking other tumors that may have not been treated even. It can also not succumb to limitations of traditional treatments like heat sink. So if you have a tumor next to a blood vessel and you try to heat it up, that side of the tumor next to the blood vessel might not heat up as much, and you might end up with residual tumor, residual disease because of the limitation. It's like water cooling off, a faucet cooling off a hot,
Right.
bowl or something. Yeah. So this heat sink effect doesn't happen with this treatment. So lots of technical benefits. There's also pros and cons depending on the size and location. It may or may not be effective. There's less science on it for certain tumors than others. So there is a lot of science to be learned, but that's one of the things that I love about interventional radiology is that we're always coming up with a new best thing, and there's always new technologies that are coming on that can improve patient outcomes.
Right. I mean, absolutely. I mean, I know you're developing non-surgical options for fibroids, for prostate enlargement, for liver cancer, for other conditions, right? Like it feels like the limit does not exist to some degree.
Absolutely. And even pain interventions. So one of the most exciting treatments to me nowadays is something called genicular artery embolization. So something as simple as knee arthritis. So knee arthritis, people used to think it's wear and tear,
Right.
and that causes the pain. And more recent science showed that it's basically there's an inflammatory component. The first few steps are inflammatory. The inflammation increases the abnormal blood vessels go into the nerves, and the sensory nerves cause the pain, and then people have pain. And knee pain is very common. Above age 60 is almost 50% of folks have it. And it can be limiting if you can't walk, you can't take care of yourself, you can't take care of your family, you can do your daily activities, you can't shower, you can't eat, you can't work, you can't do anything. And as you get older, if you are immobile and you're in bed, you can get sores and you can get clots, and it can really affect your whole life. So traditionally, knee arthritis, the treatment is you take pain pills, which don't last for a long time and have other side effects. Then you can get knee injections, which last a few months. But then after that, the next best thing is a knee replacement surgery, which is a big surgery. You have to be under anesthesia, you have to be out, you have to be in rehab for a few months or a year after to gain your strength. If you're older, you may not be even a candidate or certain types of issues. So we, in our specialty, developed a new treatment called genicular artery embolization. It's been there for a while, but now we have more science specifically for pain. It used to be used for bleeding in the knee or other issues. And we can go in, we can block using similar, beads, and there's different or other medicines to block the abnormal blood vessels while keeping the normal blood vessels open, and patients can have pain improvement. And the beauty about this, unlike the other treatments that, may be there for a few months, this in some patients you can get relief up to 24 months. So my first patient was a 90-year-old lady who had knee replacement in one leg and had complications, and she was debilitated and had issues. And she came to me, she's like, hey, her grandson actually came to me and introduced me to her. They know that I'm innovative and I do things outside the box. And this was in 2022. So this was my first case. I started the service line back then, and now we have a huge collaboration with orthopedics and sports medicine and others. But at that time, I offered her treatment, and she's done great. And to this date, she hasn't had her second knee replacement, and she had great relief, and she was so happy. She's actually a very funny lady. She would call me like every 6 months. She's like, if I need this, can I get it again? I was like, is your pain back? No, but I'm just asking because this worked and I'm not sure. Yeah. So she did great. And that what actually inspired me to introduce this, because this is technically complex. The anatomy is tricky and you have to know what you're doing. But it was something that really inspired me to push the envelope and give patients options.
And so, and you've been doing this procedure more since then, yeah?
Oh, absolutely. I've been doing it. I've created an educational website. I've done some research on the topic. I've worked with my colleagues in other departments to give lectures and to educate. And, I've helped my colleagues participate in this. So it's a team effort. It's not just me. And I also, one of the things I like anytime I build something new is I like to contribute to the science. So I enrolled our group in a national trial called the Motion Trial to understand the long-term effects of that treatment. And we're one of the national sites. The treatment is standard of care, so we can do it even without the patient being in a research trial. But if they want to advance the science by using their data, we can also. So, and I'm in discussion with other trials as well. But it's been a great journey, and I really enjoy, building these service lines and giving, patients cutting edge care. And it's what excites me about IR.
Absolutely. And so once again, the term was genicular artery embolization, right?
Correct.
Okay. So if folks wanted to actually go to your website, learn more about this, where would they be able to find all that information?
So if they type my name and genicular artery embolization, so there's an Ohio State website that is basically an article that I wrote on the topic, and it has the information of who's a candidate, how it works, who they help. It has a diagram. It also has a scheduling number if they want to come and see us. I also have an online educational video about the topic to raise awareness, and I also have several publications that they can find online. So if they type my name and the name of the procedure, they'll find it. Just very briefly, genicular is the name of the vessel that one or more vessels that we treat. Artery obviously is the artery,
Yep.
and then embolization means to block up that blood vessel or that abnormal blood vessel. So for them, they would think about it, we're blocking the abnormal blood vessels that are contributing to the pain.
Yeah. Honestly, I feel like I just keep wanting to return to the fibroid conversation. I don't know why
Absolutely.
it's sticking out to me, but I would just love to get a little bit more. I know a lot of folks, primarily women, who have dealt with serious fibroid issues, and I'm curious as to most of them ended up having surgery of some sort, hysterectomy or various procedures. But I'm curious what y'all are up to.
Absolutely. So fibroids are very, very common in women, and they're not cancer, but they can cause a lot of symptoms. So they can cause bleeding symptoms where women or patients have increased bleeding in their menstrual cycle. They can have spotting. A lot of times they have to change their pads multiple times a day. It's very disruptive. Some of them get anemic, or their blood levels or hemoglobin goes down, so they are tired and fatigued and pale and sick.
That was happening to many close friends of mine a few years ago. It seemed like everybody was just continued to run into these issues. Yeah.
Absolutely. And it's a very, very common issue. And some patients, some women, some patients might not know that they have this issue. They're, oh, I've always thought that my period is, 10 days, or it's always heavy. And I thought
Right.
that's what's normal. And obviously it can get really bad and they seek more attention. But those are the types of symptoms. They're called bleeding symptoms. They also can cause bulk symptoms. As they grow bigger, they can compress other structures. So they feel pelvic pressure, pain, cramps, because of, and the fibroids grow so big in their pelvis, the bladder doesn't fill as much, so they
Right.
end up with urinary frequency. They go to the bathroom a lot. So as you can imagine, if you're trying to work or are traveling or this or that, it's just a huge quality of life issue. And the issue is that if you have mild symptoms, they can get birth control, other medicines that can affect their hormones, and even those have side effects. Some patients can gain weight. Some of them can have depression. Some of them can have clots in their legs or strokes. So it's not even as benign as people think, but some patients like that, or some people don't, or some people want to get pregnant, so they don't want to take those. But once you get moderate to severe symptoms, you need a treatment. And the options are, generally speaking, surgery, meaning hysterectomy, where they remove the uterus. Bigger surgery, there's high risk of bleeding. They remove the uterus so they can get pregnant again. It has to be done under general anesthesia, so they'll be out and asleep, have the machine breathe for them, obviously, and the recovery is longer in the hospital and outside. But it's the right option for some patients, and it's quicker. They can get immediate results. There's a lesser version of it called myomectomy, where they remove select fibroids, but oftentimes requires a skillful surgeon, and it depends on, and they still require general anesthesia, still longer recovery, but they can select some of the fibroids, and they can't treat all of them with that approach. So that's one option. It's It's good for some patients, not good for others, pros and cons. The interventional minimally invasive option is called uterine fibroid embolization. And in that approach, we go into the blood vessels that supply fibroids, we block them, we shrink the fibroids. So it's a natural process.
Mm-hmm.
And the beauty of that is that they can keep their uterus. They don't have to have scar. They don't have to be under anesthesia. It's conscious sedation, so they're sleepy but comfortable. We can talk. They can go home quickly. And sometimes it's done outpatient same day, and they can recover quickly. Now, the pros and cons is that I think of uterine fibroid embolization as more natural. We shrink them. It took years for them to grow. It might take a couple months for them to, a few months and even longer to get the full effect. So they shrink over time. If you do a hysterectomy, you can get immediate, removal of the fibroids, but the recovery in terms of pain and bleeding and other issues may be longer. The fibroid, the IR treatment or the embolization, you're uterine sparing, which is great. And we have now science showing that you can get pregnant after this procedure, so it should not affect her. At the beginning, we did not know if it would affect it or not, but now we have data showing that it is safe to get it if you want to get pregnant, so it doesn't limit their options. And at the end of the day, if we do anything, and this is a general principle in medicine, at least in my mind, if a patient is a candidate, I think it's always best to try something minimally invasive. If it worked, you're happy, you're done, you haven't lost anything. If it didn't work, or you're not as happy, you can always do the more invasive option. But if you start with a hysterectomy or a surgery or something, when you are candidate to less invasive options, then you are basically you may be taking risks that you don't need to. But again, I don't think, I think it's a great option. I think a lot of patients don't get access to it. Many of them, tell me that they found it online, or they asked their doctor, he didn't know, or he said it might not work, and then it did, and then they went back and told him it did, or this and that. So lots of awareness that needs to be done. But that's basically how we do it.
Yeah. So would I be correct in making an assumption that your work with prostate enlargement as well is also an embolization procedure?
Absolutely. So similar to the other options that we discussed, BPH or benign prostatic hyperplasia is a condition in older men where the prostate gets bigger over time. If we all live long enough, because of the testosterone and other hormones, the prostate will get bigger. So, if you may not, but if you ever, who doesn't have a grandpa who wakes up in the middle of the night to go to puke?
Absolutely.
So, yeah, so that's a very common issue. And there are different treatment options for this issue. They can be surgical or interventional. And the goal of treatment is to help improve those symptoms. So patients may have frequent urination. They may have to wake up at night. It's called nocturia. Or they may have weak stream or dribbling or incomplete emptying of their bladder. And it becomes a big issue because in older men, they might need catheters and can get infections, and their quality of life is terrible. I had a guy the other day tell me he can't spend time with his grandkids, or can't travel, or can't do this, or he's always at home because he has to pee every hour. He has to go or find a bathroom. So it can be very, very disruptive, and it can have downstream effects. And the surgical options are more invasive. They usually involve cutting the prostate out, or cutting part of the prostate, or lasers, or different treatments that are going through the urethra or the private organ directly into the prostate. So that's can be very invasive, and patients may have strictures after, may have severe pain. They may have another thing that these procedures, some of them are at risk for, is erectile dysfunction can happen after, which is a huge thing for patients. The other option is embolization. We don't go through the private area. We go through into a blood vessel, so the wrist or the groin area, but not through, the private area, and make a tiny incision, no stitches, nothing. At the end, we go in with a small catheter and find the vessels, just like with the fibroids or other treatments we do. We find the abnormal blood vessels, we block them. The prostate shrinks over time, and then patients have improved outcomes.
Beautiful. I mean, a lot of what you're working on are similar approaches to solve different problems, which is, it's all just incredible. But I'm curious, what are you, obviously you're excited about all of this, but what are you most excited about in terms of the future of these procedures and cancer care in IR, and being an early adopter of these practices?
The future is bright, and to be honest with you, I am excited about the most simple procedure we do, a 5-minute procedure, as I am on a 10-hour procedure. That spark or joy that I've had since I was a medical student and a resident and a physician at the end has never went away. I think the elegance, the technique, and the improved outcomes that we can offer patients and just see him after and say, hey, we took care of your bleeding situation, we took care of your issue, and seeing that the impact just really inspires me to work harder and to push the envelope. But in terms of innovations, I think every single aspect of IR has something big going on. And to me, cancer care is the crown jewel. And we talked about histotripsy is a great innovation in this field where we can not only ablate tumors minimally invasively, but actually non-invasively without an invasive approach. But also, even in the Y90 or the radiation or the other chemo, the TACE or the Y90 treatments that we offer with the beads with the chemo or the radiation, there's a lot of work on immunotherapy with these treatments, combination therapies or solo therapies. And that's going to be really, really impactful because we can improve our outcomes and cure more cancers and give patients more time to live. In the pain arena, genicular artery embolization has now expanded beyond the knee. So the higher level concept is called TAME or transarterial embolization. So people are, embolizing or blocking the ankle for plantar fasciitis or the shoulder or the elbow. And there's more data coming up, and this is
Sign me
exciting. So,
up.
yeah, yeah, exactly. So and it's now has expanded in so many amazing ways, and that gives me hope because pain is a huge issue, and if we can relieve people's pain, I think this is going to be amazing. And there's even cryoablation where we freeze nerves and can treat pains that way, and blocks and other things that we didn't really discuss. But there's a lot of innovation in that field. In venous intervention, it is very exciting because we have newer devices that are more capable with less blood loss and less hospital stay and better outcomes. But also we have more data or more science showing, especially in the lung and lower extremity, that which patients we can help more. And I think this will really define the role of IR in that disease process and have significant impact. So those are the three areas that excite me the most. But the way I look at my specialty, every single area, I see great progress. And another thing that affects all of it's actually artificial intelligence,
Of course.
AI. And that's a whole different world that we haven't discussed as much here today. But that's going to help us, deliver better treatments, pick better options, figure out which patients are responders and which ones are not before we even do a treatment, and help us become more capable. And not only during the procedure, but also through every phase of the patient's care. So AI can help us with, scheduling. It can help us make sure patients are lost for follow-up. It can help us create patient educational materials that are easy to read or in different language if the patient doesn't speak English. Or create AI chatbots for, after hours, if somebody calls at 2 a.m. and there's no specialist available, and is this pain normal? Is this not? I had this procedure, for basic questions. So if you think about it, AI is going to touch every single aspect of interventional radiology and in medicine in general. And I'm part of the group that's thinking that it will be for the positive, and we just have to leverage it and use it to make our job better and to make us more effective for our patients.
Yeah, absolutely. And also, how about us doing an hour and a half long-ish recording talking about cutting edge medicine where we don't touch on AI until the very end? I just have to say, that's pretty impressive.
Well, IR is just, there's just a lot to cover.
Yeah, absolutely.
But I'm glad the two approach is great. You ended up with a bang on the. You have the innovations. So this is the innovations episode, and the other one was the overall episode. Yeah.
Yeah. I mean, it's 11:01. So let me just say, Dr. Makary, thank you so much for joining us today on Rethink Imaging. It has been an utter pleasure to talk with you, and I hope to stay in touch and talk with you again sometime.
Absolutely. Thank you so much. I really enjoyed our conversation, and this was really insightful, and we touched on many amazing topics. I hope our audience can also appreciate this, and I look forward to future collaborations with you.
Absolutely. I know they will. Thank you so much.
Thank you.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.